the background of cardiology, vascular medicine, and immunology with specific training and expertise in key research areas for this application. After graduating from Osaka University School of Medicine in 1996, he received clinical residency training in internal medicine and cardiology at Osaka University Hospital, National Osaka Hospital, and Osaka Medical Center for cancer and cardiovascular diseases. In the year 2000, he entered Osaka University Graduate School of Medicine to conduct basic research on molecular mechanisms of cardiac hypertrophy via cytokines and growth factors, which led to his PhD in cardiology. Then he received further training of basic research under Professor Mochizuki in National Cerebral and Cardiovascular Center Research Institute during 2004 till 2007. And he was engaged in elucidating of the roles of angiopoietin 1 in heart development and coronary vessel formation. Coming back to Osaka University, he started basic and clinical research on the molecular pathogenesis of intractable vascular diseases, including pulmonary arterial hypertension and Takayasu arthritis. He examined the effects of interleukin-6 blockade in animal model of PAH, pulmonary arterial hypertension, and in the patients with Takayasu's arthritis. And he revealed that interleukin-6 is a key player in the pathogenesis of both pulmonary arterial hypertension and Takayasu arthritis. He has been conducting a translational research project examining the effect of anti-interleukin-6 receptor antibody tocilizumab for the patients with Takayasu's arthritis as a principal investigator during the year 2008 to 2017 in collaboration with Chugai Pharma in Japan. This project resulted in approval of tocilizumab for Takayasu arthritis in 2017 in Japan. Professor Nakaoka is also an able disciple or the student of his mentor, Professor Tadamitsu Kishimoto, who is the one who discovered the molecule of tocilizumab. I now welcome Professor Nakaoka to deliver his talk. And the title of the talk is Takayasu Arthritis, Update on Pathophysiology, Diagnosis and Treatment.
Thank you for a kind introduction, Professor Danda. It's a great honor for me to present our recent work here. I'd like to thank the organizing committee of the APLAR for giving me such a nice opportunity. Today, I'd like to talk about Takayasu arthritis as Professor Danda introduced for me. This slide shows disclosure information for my presentation. And I'd like to start this slide for my talk. Takayasu arthritis is classified into the large-based vasculitis according to CHCC 2012 classification criteria. And as you may know, Takayasu arthritis was first described by a Japanese ophthalmologist, Mikito Takayasu, who was born in Saga City. He reported a case of Takayasu arthritis to a 22-year-old female patient with coronary anastomosis around the papilla. He reported this case at the 12th annual meeting of the Japanese Ophthalmology Society in 1908 at Fukuoka here. So he reported this case 115 years ago. According to this finding, this disease was called as Takayasu arthritis. Today, I'd like to talk about treatment of Takayasu arthritis in the first part of my talk. And I'd like to talk about the role of gut microbiome in the pathogenesis of Takayasu arthritis. This slide shows the pathological features of Takayasu arthritis, and this is a representative pathologies of the vascular region of TAC. Nociton loss of elastic fibers were frequently observed in the outer side of the media. And in this region, we can see a multinucleated giant cell right here. And these cells eat elastin, the component of the elastic fibers of the medial layers. And this destruction leads to the compensation in the outer adventitial fibrosis and furthermore, intimal thickening. This remodeling leads to thickening of the vessel and the stenosis regions. And in this cartoon shows the progression of the large arterial region in the TAC, and in some vessels, dilation and aneurysm was formed. In some vessels, stenotic and occlusive regions were formed in the patient with TAC. This slide shows a young female patient with TAC who needed to undergo cardiovascular surgery due to aortic aneurysm formation in the thorax. She needed to undergo surgery with synthetic graft at 25-year-old. In the patient with TAC, cardiovascular complications associated, like aortic regurgitation, ischemic heart disease, aortic aneurysm are frequently observed. We needed to prevent these complications through the medical therapy. There is a clinical issues in the treatment for TAC. The patient with TAC usually respond to steroid when administered in high dose. However, a sizable number of patients, more than half, relapse on tapering of steroid. Sustained remission for over 6 months while being treated with less than 10 milligrams of prednisone was attained in only less than 30% in the US cohort study. So we needed to develop a new novel therapeutic strategy. We focus on IL-6 because serum level of IL-6 is correlated with disease activity. We examine the effect of IL-6 blockade by tocilizumab in the refractory patient with TAC. Tocilizumab is, as you may know, is a monoclonal humanized IL-6 receptor antibody developed in Japan. This drug is created by the collaboration between Osaka University, Professor Kishimoto, and Chugai Pharma. And this drug is widely used for treatment of rheumatoid arthritis, Castleman disease, and juvenile idiopathic arthritis. We enrolled 4 patients in the pilot study in 2008, 3 female and 1 male. And these patients were treated with glucocorticoid monotherapy or with immunosuppressing agent, and they could not reduce steroid dosage less than 12.5 to 35, as shown here. We administered tocilizumab intravenously, 8 milligrams per kilogram for every 4 weeks, and 24 to 51 times tocilizumab administration leads to tremendous reduction of steroid, as shown here. I'd like to show the case 1 clinical course. She was the most difficult to treat patient in my clinical experience. She could not reduce the dose of prednisone less than 35 milligrams per day, even with cyclophosphamide or azathioprine or methotrexate administration. She was referred to our hospital, and tocilizumab was used every 4 weeks, and the dose of prednisone could be reduced from 35 to 2 during the 4-year treatment with tocilizumab, as shown here. Furthermore, the thickened region of the brachiocephalic artery here was improved after treatment with tocilizumab more than 2 years. In pilot study, we found that tocilizumab might be effective and well tolerated in the patient with TAC, and the 2 patients among the 4 showed improvement in the thickened arterial regions. We move on to the clinical trial for obtaining POC, and furthermore, Chugai Pharma started a sponsor-initiated randomized control trial from 2014 to 17, and we could get an approval from the Japanese government in 2017 for treatment of Takayasu arthritis. This slide shows the design of TACT study. We enrolled patients older than 12-year-old diagnosed according to JCS guideline 2008, and patients should be relapsing while treated with prednisone more than 0.2 milligram per kilogram a day. And the dose should be elevated at least twice and introduced into remission. And after that, patients were divided into two groups, tocilizumab or placebo group, and the forced tapering of prednisone was performed in the double-blind period, and the patient showed relapse. They move on to the open-label period and treated with tocilizumab subcutaneously. And the dose of prednisone could be determined by the discretion of the investigators in this period. And this slide shows the primary endpoint of the double-blind period in the ITT population. Tocilizumab showed a trend toward suppression of relapsing. However, the primary endpoint did not show statistical significance with a p-value 0.0596. So we next evaluate the long-term efficacy and safety of tocilizumab in the patient with TAC in the real-world clinical settings, where a steroid dose can be adjusted at the physician's discretion. This is an open-label period. We compare the dose of prednisone between baseline and after tocilizumab treatment of 96 weeks. We also compared imaging data and SF36-based health-related QOL data. This slide shows that tocilizumab, long-term treatment with tocilizumab showed steroid-sparing effect, as shown here. Over about 2-year treatment with tocilizumab, the dose of prednisone could be reduced, as shown here. Furthermore, we also found that the health-related QOL data were improved by treatment with tocilizumab 1 year or 2 year, and the data became close to the age-sex matched norms data. So tocilizumab provided a steroid-sparing effect, improvement in patient well-being, and stable or improved disease on imaging evaluation. Based on this data, we could get approval from the Japanese government to use this drug for treatment of Takayasu arthritis. And if this is a guideline described medical treatment for TAC, if patients show resistance to prednisone, patients should be treated with these second-line treatment drugs. Tocilizumab is included in the second-line drugs. And these days, tocilizumab is widely used in Japan. On the other hand, several case reports regarding the detrimental or worsening effect on the vascular complication in a patient with TAC treated with tocilizumab. This case report indicates that the worsening of thoracic aortic aneurysm were observed in the patient with TAC. However, regular imaging tests would be a key to detect the worsening of the vessel condition in the patient with TAC. So we aim to investigate whether tocilizumab treatment inhibited the progression of vascular lesion caused by TAC in the patient who participated in the TAC study. We evaluated 22 arteries shown here. 22 arteries from each patient were assessed for change from baseline in wall thickness, dilatation aneurysm, stenosis occlusion, or wall enhancement for at least 48 weeks after tocilizumab initiation. These evaluations were conducted by 3 independent radiologists who were not involved in the original TACT study. We examined the baseline data and the data at week 48 after tocilizumab initiation and at week 96 after tocilizumab initiation. And this is a key result of the per patient arterial region. As you can see, in the dilatation, aneurysm, stenosis, occlusion, wall enhancement, most patients show stable or improved, as shown here. On the other hand, in the wall thickness, about 40 patients showed partial progression or new regions. In this meaning, wall thickness is the most sensitive detection item for the evaluation of the CT angiography in the patient with TAP to detect the relapse. Among these 28 patients, 8 patients were positive for their new lesion in the wall thickness. Among these patients, dilatation aneurysm new lesion, stenosis occlusion new lesion, and wall enhancement new lesion, these lesions were covered in these patients. Not new lesions in these 3 items were observed in other patients. So, in summary of this study, wall thickness new lesion likely resulted from refractory TAC. Patients who experience this should be monitored carefully by imaging, and additional glucocorticoid or immunosuppressive treatment should be considered to avoid vascular progression. I would like to move on to the last topic, gut microbiome as a predictor for aortic aneurysm in Takayasu arteritis. This slide shows the clinical issues of tocilizumab treatment for Takayasu arteritis. Tocilizumab treatment leads to a negative CRP condition in the serum. We administered tocilizumab in these patients, and we tapered prednisone dose, as shown here. Along this tapering, IMT, intima medial thickness, the thickness wall thickness evaluated by ultrasonography were worsened during the tapering of steroid. However, CRP was negative. So, however, we increased prednisone dose, as shown here, due to because these data were worsening, and the serum iris level also increased. And in this patient, this worsening of the thickening was improved by additional treatment with prednisone. The effective biomarker, which can detect inflammation or worsening during tocilizumab treatment, has been awaited. So we focus on the microbiome, and we investigate whether the gut dysbiosis exists in the patient with TAC, and to identify specific gut microorganisms related to aortic aneurysm formation progression in TAC. We conducted 16S metagenome analysis. We compared the data from the healthy controls and the TAC patient using CHIME2 analysis and comparative analysis of gut microbiome between these two groups, and a comparative analysis of gut microbiome between TAC patient with aortic aneurysm related events and without these events. This slide shows the baseline data of the patient with TAC and healthy controls. We enrolled 67 TAC patients and age-sex matched healthy control patient. 56 healthy controls were enrolled in this study. This slide shows the data of the background data of this microbiome, gut microbiome. In the alpha diversity, there is no significant difference between two groups, healthy controls and TAC patients. On the other hand, in the beta diversity, there is a clear dissimilarity between the two groups, as shown here, through weighted unifrac analysis and PLSD analysis. Furthermore, microbiome dysbiosis index showed that in the TAC patient, this index is increased, significantly increased compared with healthy controls. Furthermore, we found that the patient with TAC showed gut dysbiosis with a higher abundance of oral-derived bacteria at the genus level, including Streptococcus, Lactobacillus, Haemophilus, and Campylobacter. Why these oral-derived bacteria are ever increased in the patient with TAC? We examined the relationship between drug administration in the patient and the abundance of Campylobacter at genus level. And we found that this increase of Campylobacter was strongly correlated with administration of proton pump inhibitor. Proton pump inhibitor is widely used for the patient with TAC because aspirin or antiplatelet agent were frequently used for the patient with TAC to prevent thrombotic events. So we focus on the patient with TAC who are treated with proton pump inhibitor. And we compare the gut microbiome patient with TAC with and without a prior history of aortic aneurysm-related events and found that Campylobacter at genus level and Campylobacter gracilis at species levels is increased in the patient with event positive. Next, we examine the effect of Campylobacter in the gut microbiome. We prospectively analyzed the event-free survival in relation to aortic aneurysm. Campylobacter positive or at genus level or Campylobacter gracilis positive level at species showed poor event-free survival in relation to aortic aneurysm formation. Furthermore, PCR-based positive for Campylobacter gracilis could discriminate the prognosis. On the other hand, conventional inflammation markers such as CRP could not discriminate. Furthermore, severity of aortic aneurysm are related to positivity of Campylobacter gracilis in the gut, as shown here. Campylobacter gracilis PCR-mediated positivity were indicated as red line. On the other hand, negative was black line. And this patient did not undergo cardiovascular surgery due to aortic aneurysm formation. This was the control, and Campylobacter gracilis positive patient tended to overweigh this patient mean maximal short diameter in 4 regions of the aorta. In this meaning, severe aortic aneurysm are associated with positivity of Campylobacter gracilis in the gut. So, patient with a gut microbiome positive for Campylobacter showed a tendency to have severe aortic aneurysm in the patient with TAC. A specific increase in oral-derived Campylobacter may be a novel predictor of aortic aneurysm formation progression in the patient with TAC. These data are derived from the only 3 institute sample collection. So we are now progressing this study to the nationwide collection from 15 institute in Japan. We got a grant from EMEDO, Japan funding agency in this year, and we would like to show further data in the near future. We have recently published this result in ART. Thank you for your attention.
Thank you, Professor Nakaoka, for excellent work on the recent work, especially on microbiota and Takayasu's, which is new information. I congratulate you on your good work. Is there any question from the chat box? I can't see anything here.
So can I have a question, Chairperson?
There is.
Professor Nakaoka, so Yu Kwang from Singapore. Just wanted your views on isolated aortitis. In your experience, how do you differentiate that in patients with Takayasu with single artery territory? Whether there are any difference in the pathology and also the treatment?
Yeah.
Thank you.
Actually, that is a very important issue, and we are actually conducting a pathological clinical study in collaboration with a section of pathology in our institute. And we are comparing the pathological regions of the patient with TAC and the isolated aortitis patients data. And we are checking the expression level of the various cytokines, including IL-6 and TNF and so on in these patients. However, there is no definite clear difference between these samples. And we are now checking other cytokines now. So at this time, I could not write comment to your question. Thank you. Treatment. Yeah, actually, isolated aortitis patient accumulated in the department of surgery, not in my outpatient ward. So I didn't know the clinical cross data. So we are now collecting the data regarding the that kind of clinical settings. Thank you.
We have 6 questions in the chat box, but I think for the shortage of time, we're already 10 minutes behind schedule. We have 11 more talks to go. I'll just take one question from the chat box, which says that, do you routinely screen for coronary artery involvement in Takayasu's arthritis?
Thank you. Actually, we check electrocardiogram every EKG every year. However, we didn't check the coronary CT angiogram routinely. We routinely check the EKG or UCG, cardiac ultrasonography, are routinely checked. If patients show or complain about the ischemic symptoms, we perform our CT coronary angiogram. Thank you.
Thank you. I think the remaining questions will answer by mail to the attendees. I will now invite the next chairperson, next two talks chairperson, Dr. Samuel Whittle, followed by which his
Thank
own
you.
talk. So he'll be here for next three talks. Thank you. Welcome, Dr. Sam. Thank you. Congratulations, Dr. Nakaoka.